So we can finish on time. There's a lot of slides. Okay, so this presentation entirely was done by John Maggio, okay? In John, what he did basically, you're gonna see there's about 13 scenarios. Each scenario, he did not come up with it on his own. He found a research paper and he just brought it to us. And he wants to compare our answers with the research paper answers. So there's nothing in there for him that he injected his own personal, not mine, nor anybody else. Okay, so this is just basically what's the current research showing. We may agree with it, we may not. That's why the discussion is gonna be hopefully nice. So we're gonna start with the first two scenarios. Is about deep caries lesion. The scenario one, okay, so if you have a patient with deep caries occlusally and reversible pulpitis on a posterior tooth where the caries appears to extend to the pulp, which option do you most often choose? So you have those three options. You stop before removing all the caries, and you do indirect pulp cap, remove all the caries and you do direct pulp cap, or you go all the way and you do endo. Okay, so those are the three options so far. Now, there's no x-ray with this. It's on purpose. That's just like that. The second scenario, now a little bit different. Edwards is 25-year-old male with visible cavitation. You can see it here. I'm not sure how clear from far. And the central fossa of tooth number 30. And also, overall, he has only 2 enamel lesions on the smooth surfaces, in addition to this one here, the deep caries on number 30, where the bi-wing showing it. Now, the question is, the tooth responds to cold and the pain less than 3 seconds. Okay, so deep caries, again, the patient doesn't have many active, doesn't have active caries anywhere else, just 2 enamel lesions, respond to cold and pain less than 3 seconds and goes away. Upon opening the tooth during the excavation, we realize that the lesion is deeper than we expected and may involve the mesial buccal pulp horn, okay? So, was big, maybe, may not open to the mesial buccal pulp horn. What would you do? Do you continue remove all the caries? Stop removing the caries near the pulp horn and remove it elsewhere? And temporize and treat or refer to, for endo. So 3 things. Either you remove all the caries, and then you take a chance of having that open to the pulp, or you stop where the caries is deep and you think you're gonna, you're gonna expose, or basically send it for endo. Now, what's the correct answers here? For scenario number 1, what would you do? Most of you, what would you do on scenario number 1? Would you stop before removing all caries and perform an indirect pulp cap? Or you remove all the caries, and if you expose, you do direct pulp cap, remove all the caries and you do endo related procedure, given that the patient didn't have any symptoms before? So what would you guys do?
Well, wait, you say he's got reversible pulpitis, that's symptoms.
Right, but it doesn't last. There's no lasting, so reversible pulpitis. There's a symptoms, but...
There are symptoms.
Right, but it's not lingering symptoms.
It's not what?
Lingering symptoms.
Okay.
I continue until I'd like to see where the caries goes, and I do an indirect pulp cap if necessary.
Indirect, okay.
Oh, excuse me, is there one for direct? No, direct
Yes,
number 2.
Yeah, the top
I
one,
proceed to see if it is a direct.
the number 2.
Number 2, yeah.
So you do number 2,
I would.
pulp cap, direct.
Well, it would seem that with a reversible pulpitis, one of the things we'd like to do is see if we can resolve the symptoms. So caries removal and an indirect pulp cap with a temporary restoration would probably be, in my mind, a reasonable way to go. Symptoms resolve, and a couple months later go back and do a definitive restoration.
Okay. Any other?
What would your temporary restoration be?
IRM, typically.
And what was your cap? That's what you replaced? It would just be IRM
No, pulp cap.
with?
Probably with something like ultrafine or
Less hammer or ultrafine is calcium hydroxide.
calcium
Yeah.
hydroxide.
Calcium
You
hydroxide.
could get calcium hydroxide based pulp cap and IRM as a material that's relatively easy to remove and yet quite durable.
Okay, so the answer to that, they said the same thing, that you stop just before and you do indirect pulp cap, was it 22%?
So this was a survey?
It's a survey, yeah, it's a research survey.
Okay.
Okay,
This is from that Caries, that national network of practitioners research.
and that's, yeah, from 2013, doesn't show here, Norton. For scenario, oops, no, well, you saw it right now. Scenario number 2. Remember we said that maybe we thought could be really a lot deeper than we expected. It may open into the mesobuccal pulp horn. The survey said basically that you stop removing caries near the pulp horn and remove it elsewhere. It's basically, indirect pulp capping the same. So what the paper is saying, that if you have a healthy tooth with a deep lesion and you have just minor pulpitis, that you want to resolve it, so you don't remove all the caries. What you do, you remove most of it, you temporize it, and then you go back to it and see if that resolved. Then you keep going with a more permanent solution on that one. Okay, so according to a lot of papers that you can see, and especially Kidd and Ricketts and the others, that if you leaving soft caries over the pulp, you basically avoid bulb exposure, result in less post-op symptoms, and provide restoration that lasts as long as the complete caries removal. That's the finding. They, from probably as early as 2004 till probably now. Pulp exposure must be avoided at all the time, but if it happens, we think it should be, not we, me, and John, but the research, so it should be considered iatrogenic, okay? So basically, a direct pulp capping procedure should be necessary only if the operator exposed the pulp in attempting the indirect pulp capping procedure. Okay, so with deep caries lesion, the indirect pulp capping procedure is always preferred to direct pulp capping procedure, and that's from Summit James and his al. That's for the contemporary approach for caries treatment.
Body, can I just, these things are very different from what we were taught and what we used to teach. I remember with endo, it's always never do an indirect pulp cap, never. We don't do that. Always go, if it's going to be in the pulp, you do the endo, boom. That is very kind of old philosophy based on the evidence of what caries management was.
Yeah, and also teaching the REB, the NERB was a different story. The REB, part of their philosophy is they said to the students in the manual that all pulpal exposures considered avoidable, even if you're expecting that's going to happen. So they want them to do indirect pulp capping, basically. And that's where we had a couple of failures. Our guys went all the way and they opened it, so they lost a few points. And that's basically mostly, the rep is mostly the western part of the United States. Maybe dental schools, they agreed on that. Doesn't mean that this is the, the proper way of doing things for us or anybody else, but I need to let you know that's what's going on in terms with the rep too.
In terms of caries removal, there seems to be a lack of clarity in terms of what should and should not be removed. And many of these discussions focus on those things which are close pulpally, but no one is saying anything about peripheral caries. And one of the things that has classically been presented was that the removal of all caries at the DEJ is important for properly establishing an outline form for the restoration and being able to establish a good periphery for whatever type of restorative material you're using. But this seems to be not emphasized at all anywhere.
My talking with Dr. Sabatini, I really think she does it in the pre-clinic, but I'm not sure if John is lecturing about it for the juniors. The sophomore are, but I'm not sure about the juniors. So I will ask him. I mean, that's a good question.
I think in some discussions I've had with him, I think there's an agreement that the DEJ should be established as
The point.
no discoloration at the DEJ, which would be the definition of the extent of caries at that point.
Okay.
And all other things internally are subject to other.
Yeah, and also, you're right, and there's a lot of confusion and no clarity, as you said, also in how you remove gross decay, how you approach it. You know, a lot of students, they go right away into the axial wall, pulpal floor, not establishing the outline, not cleaning all the stuff. So that goes to what you were saying, yes.
Peripherally established
Exactly.
outline form, which was always the basic move for beginning a preparation to establish the outline form. And then move internally, and as you progress closer pulpally, then these
You make a decision.
come in terms into play for judgment.
Right.
But that doesn't seem to be particularly emphasized
Okay.
anywhere or in our clinics.
Okay.
But we should be. I mean, you're in agreement. I agree with that too. I mean, we're in a different environment also. It doesn't seem reasonable to just glob in some calcium hydroxide over the whole amount of caries. That would be only where the pulp exposure is at the greatest risk.
Yeah.
So we could.
Yeah.
If we're doing an indirect pulp here in the clinic, what is so we're always re-entering the tooth, placing a temporary and re-entering the tooth at a later date with a definitive restoration?
Well, that seems to be a question also that lacks clarity in terms of definition with what an indirect pulp cap is. Originally, it was, I believe, defined as exactly what Lauren is saying, that you place material, temporize, go back and
Put a new.
and restore later. However, the much more commonly referred to approach of indirect pulp cap is simply put something over deep caries and restore the tooth.
Right.
Right. I'm leaving caries, but as long as I put something over it and right in the chart it's indirect caries or indirect pulp cap, I can put my filling in. Okay. So which way is it? Which way should the students be directed?
Well, according to my conversation with John, he thinks the best temporary filling is to put the final filling, the final restoration.
Best seal, best.
So we use usually some kind of glass element to maintain the seal because otherwise it's not effective, but that doesn't mean that we need to re-enter, and that's what Dr. Maggio will do about in 6 months or so, 3 to 6 months, another radiograph and re-entry.
So we're talking about definitive restoration or?
Not anything indirect. You can't go in and do, I mean, from my perspective, we're not going to do an indirect restoration on a tooth that had a direct pulp cap that we had gone in for a re-entry and evaluation.
Okay, so
Diagnosis.
we're saying indirect pulp cap requires re-entry and re-restoration.
Re-restoration.
Whatever your interim material may be.
It could be, yes.
And what is the time frame?
I read,
These are the things that have to come out of this in-service, is what is our policy going to be?
yeah, there's a couple of slides here, we'll discuss that.
Right.
But the paper that John provided, they were talking about 6 months.
6 months?
I think
Yeah.
That's generally accepted, is 6 months, I think.
Yeah, so,
Take that long for the odontic flash to...
To get activated and do something?
okay, so the second modules,
You, 6 months, then you remove all the caries after that?
Well, you go in and you investigate. to see
Investigate.
What the state, the
Right.
status of the caries is. Is there secondary dent formation? You're still gonna go over your endodiagnosis, your pulpal diagnosis.
I think that's the important part,
Yes.
you know.
Yeah.
6 months, the first thing you do is
You
you
do
do an
the
endodontic
diagnosis.
screening.
mhm,
I mean, let's not go in and do a
And go-
asymptomatic non-vital
exactly.
tooth and think we're going to
Exactly.
do something.
Right.
okay, scenario number 3. So we have a patient has 5 existing restoration and is not missing any teeth. What treatment would you provide to the restoration? This one here. Okay, so those are all the options in here. There's 9 of them. No treatment, follow-up, plaque control, tell them to brush around it really well, that just you do varnish and maybe tray fluoride in office. You prescribe fluoride, or non-prescription, you seal over it, chlorhexidine treatment over the area, polish, resurface, or repair restoration. Last one is to replace the entire
Is it a
restoration.
restoration or is it an emulation?
No, this is a restoration.
Just trace it there so they can see where it goes.
Yeah, I mean, the problem is this is too fuzzy, you cannot see it. Goes here.
That's the coronary aspect.
Is there cavitation?
Clinically, is it carious or just defect with discoloration?
That's the way it is.
That's the way it is?
I have no idea. That's what it is. They said this patient come in and
You have a 3D,
don't start with the 3D. Okay, scenario 4. We have existing restoration and some kind of stain and stuff going on in there. I'm not sure you guys can see it really well.
You see, that's kind of the distal half of that cervical
Lesion here.
restoration.
So this patient has no other dental restorations. So no restorations at all. No dental caries and no missing teeth. The only problem they have is this one, okay? What treatment would you provide? It's exactly the same series of the other one. Last scenario here is the patient has no other, the same thing, no dental caries, no missing teeth, and what would you do? So let's go to the first one. What option you guys would do right away?
H.
Polish, resurface, okay? All of you the same? Okay.
Yeah.
Okay. Anybody would replace entire restoration? Okay. Anybody would consider sealant or unfilled resin over the tooth?
Not without the items of age. You want to
Right.
evaluate what happens when you try to remove that marginal stain. Is it just a little flash? Is it something that cavitates? Does the stain progress underneath?
Right. Okay. Scenario 4. Not sure you guys can. I'm gonna just turn it off just really quick. I'm not sure if you can see it better. Don't sleep. Okay, so it's here. So what's the option here? So
Did you put your pointer on my screen?
no, I can't.
Can you do half the lights? No?
Other hand.
Is it good?
Yeah.
All right. All right. So that's existing. There's something going on here. No other caries in the mouth, nothing, 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 everything's good. You see this patient, what would you do?
I would like to H again.
H, right? H. Okay. The amalgam here. It's the same scenario. What would you do here, here for that?
How long has it been there?
This is what you see. I have no idea. It's obviously it's really an old one. There's a lot of ditching around it. So look at beating A. No treatment. Okay.
Are you allowed to stick your Explorer there in between
Yeah.
that amalgam and that tooth?
It's coming. It's coming. It's coming.
I mean, it's open. If it's open, I mean, you go over it and
Remarginate, right?
well, and then if you open it up and there's something, then you,
Do we have a radiograph on this?
No.
oh heavens no.
That's not.
No.
Well, I wouldn't recommend,
You don't see anything on the radiograph. I'll
Oh,
tell
you don't see it?
No,
Okay,
there's
so
nothing on the
good.
radiograph, okay? We'll just assume that.
No, she's saying, you're just assuming that now.
Assuming there's no radiographic evidence of caries.
no radiograph, okay.
So most of you guys, you're going with A.
Right, because this is surface stitching, I mean, to our knowledge now. As far
Our
as we can
knowledge,
see, it's
that's what
surface
we think it
stitching.
is.
There's
Right.
no leakage, I mean, associated with surface stitching of ammonia because of corrosion products. It seals very well, so
Okay.
at this point, nothing.
For scenario number 3, definitely no replacing the entire restoration that all of you agreed on, which is really good. 42% they said they would replace the entire restoration. 42% of the dentists that were surveyed. But any of those, according or combination, it's acceptable to try to treat that in your office.
What is chlorhexidine going to do?
Antibacterial.
And bacteria, kill the bacteria.
Stain it.
Stain it. Yeah,
What's the reason they come back again?
right.
Now we gotta replace it.
Exactly.
But just,
You do G and then you can do I. Then you can do I.
Yeah. Scenario 4. 67 said they will go and replace the entire restoration. But any of those, they said it's acceptable. Last one, and then I'm going to ask question later on, that's for me. 65% they said they would replace the whole entire thing for that.
With composite, I'm sure.
Probably. So the question, I don't know, is there any difference in treating this between your own office and under your own supervision or here in the school? Should we consider that when we treat lesions like that in a school where the patient may not show up, may disappear, versus your own office? This is your patient, you know they're coming, you have better control over it. Should we consider that how we treat things in the clinic?
Should we be more aggressive? More aggressive?
Yeah, I mean, yeah, that's what I'm thinking.
But our consensus appeared to be mostly H in the.
Right.
And generally in the clinic, what I would present to a student is if we have a marginal issue with a resin restoration, that the treatment is predicated in part in how much of a marginal issue and how large an existing restoration. If it's a very small restoration with a marginal issue, perhaps replacement would be just as well. If it's an extensive restoration with a small defect, clearly we should repair the small defect, and then you have to make judgments somewhere in between.
and with something like this, if you're going to go in and excavate, or explore that, I certainly would, I don't think I would put a composite there on that root surface.
That's the other point.
I
It
would
appears
use
to
a
be a
glass
bond
ion.
failure at the gingival.
Right.
surface.
So using a glass ionomer in that situation, which is what, for classified, anything on a root surface, you want to use glass ionomer.
Right.
And
When you
tissue
can.
management probably too.
Pardon?
Because, I mean, what I tell students is that this probably was not placed perfectly, because probably the tissue was not managed well, there was inadequate isolation. So it started with an issue at placement, and that's how it presented later on. So.
Okay, is anybody at all will consider just the in-office fluoride, like varnish and trays, to manage this?
If it's not cavitated.
Alone?
Caries,
Alone, yeah, that's the question here.
And no aesthetic
If it's not carious.
And if it's not an aesthetic concern and it's not flag retentive, why not? It's just a defect, yes.
Well, it looks like you've got a rolled border on the tissue there. That may be a consideration.
This one here?
Yeah.
Yeah.
It's a little different than the central one.
Right.
Mm-hmm. Okay, that's good. Yeah.
Certainly with this prescription.
This is
for it.
old school again, but I'm concerned about having students getting used to replacing everything. It's a total replacement, like everything that's stained, everything where the margins, like on that amalgam, weren't perfect because it's been there for 15 or 20 years. Because I've seen, maybe they're trying to create business, but I've seen too many people crown teeth with a two-surface amalgam because they say it's too large, we have to have a crown. They're just trying to increase their production. Are they really doing the patient a service? Like on that amalgam.
Right.
People would crown that, which to me is, again, that's old school, so I have to have some direction here.
And there
Yeah.
are cracks going over every, a marginal ridge, down the lingual groove, the buccal, that kind of thing. I think you,
Wait, but I wanted to make a similar observation because out of those three...
Which slide?
Right now, with
Okay.
scenario 5.
Yeah.
Out of the 3 last scenarios, my main concern, talking about the clinic, and I don't know if everybody agrees with me or not, was scenario number 5, meaning approximately 90% of the time, if I would sit down and look at the treatment plan and work with the student, that restoration is scheduled to be replaced or crowned.
I agree on replacement, definitely. I
That's why
agree.
it's very important when you go over that tomorrow and on Wednesday to really stress that, because really, especially the last 2-3 years, I see that on a treatment plan all the time, at least to be replaced, very often to be crowned.
well, one of the reasons for that is our requirements. That's a big driver. For
Yes, but the
students-
faculty signs that.
I know.
I'm not talking about the non-experienced student who wants a 32 CPUs for the crown.
I know what you're saying. I'm just saying that's one of the reasons that we should not be doing that.
Well, I think there is something more to it than that, though, honestly. I think, we're in an institutional setting, and so it's not the same eyes looking at it at every 6-month recall.
Right.
And so, it's a little different than a private practice situation because, is that the same amount of ditching as it was the last time somebody saw it? And I think so. Where do you draw the line?
Yeah, I mean, that's why I asked that question, what we do in the
And
clinic.
there's obviously a fair degree of subjectivity that enters into it.
Well, take this, what if that mesial area is, or distal, I mean,
This one here? Yeah.
where it's quite dark and, oxidized, if you decided that that was too cavitated, maybe caries, what if you were to go in and excavate very conservatively and then fill it up with, or restore that area with a composite?
Why composite? Why not amalgam?
Well, neither of them are going to bond to the amalgam.
Neither is the
Yeah, but,
composite,
I mean-
but
I know,
at least the
neither of them
product,
are.
I mean, it's gonna seal it and you're gonna pack it.
Well, that's what I want, that's why I'm bringing it up.
Yeah,
because
that's the one question.
We had a discussion about it, John and Fadi and Camilla and I, about what would we do?
I mean, yeah, what would you replace it if you removed, let's say, this area here? What's the
I think
choice?
there's no aesthetic consideration. You repair an amalgam with an amalgam.
Okay.
Okay, I mean, this is what we're trying to,
Would anybody consider putting an amalgam in there and then you seal over it?
why not?
Seal.
I mean, amalgam in there, yes, seal over it. There was a paper actually, repair it, seal it, or leave it, and I have to pull it up, but sealing would not do a better job compared to just leaving them. If the patient is gonna come back for regular recalls, with somehow lower caries risk. So I think it's a combination of factors. It's
Right.
every patient is treated on an individual
Right.
basis. If the patient comes on a regular visits for a checkup on topical fluoride, or at least uses a fluoride-containing toothpaste twice a day, can be over the counter. And with lower caries risk, then you probably can just watch it. But if it's
Yeah, well, the reason,
the patient leaving for a while,
yeah, the reason I asked this question, because it's being taught in a junior lecture course that when you repair it with amalgam, you seal over it. So if this is not really translated to the clinic, because most of the faculty don't believe in it, we need to know so we can adjust either way. I mean, I don't see, personally, I don't see any advantage of sealing over that.
I think some years back, John Osborne put out a paper talking about sealing old ditch margins, but I don't know what kind of long-term follow-up there was based on what he was saying, but I'm personally not in favor of sealing over amalgam restorations, either old ones or
New ones.
The new one,
Right.
okay.
Is it too confusing for students to say, if we determine that maybe we should replace it and then see if the cuts are undermined, how strong the distal margin is, and then determine whether we should do a crown? That's what we might do. But is it too confusing for students? Do they want to know should they know what the onset? It's likely going to be a crown, it's going to be a
They don't,
I mean, this is usually it's an active discussion between the instructor of that day and with that student. And if they're going to, let's say, they want to replace this, or they want to do crown on that, you have to have reason why you have to put in there. So that discussion happened.
Crown anyway.
Yeah.
You're going to do a onlay, a ceramic onlay. of some
Well, one of
sort.
the things that I always tell a student when they have a replacement, the replacing restoration is, let's get the old restoration out and see what we have to work with.
Right.
Yeah.
If we're going to replace.
Well, I mean, assuming we're going to remove a restoration, it's not that we are doing this particular procedure, but let's get the restoration out and look at what we have, which may affect how we want to approach restoration.
Right.
Okay, good.
Certainly inclusion plays a
Yeah.
So that doesn't look like those doing half is going on that.
I mean, that's obviously, it's very true statement. According to evidence, sound tooth structure is removed and cavity is enlarged anytime you replace the whole entire thing. That's some of the slides that basically this is, staining. I don't think any of us will go in there and try to repair it. It is very evidence that there is a flash here around it, so I think finishing up polishing can resolve the issue or can show there is a problem. The same
You could seal over that with.
same here.
Fuji coat or Fuji, a composite sealer. If you were to go in and refinish them?
Oh, if you were to
If you were going to refinish?
Refinish it.
the durability wouldn't be very.
Yeah, Gordon said that replacing restoration can negatively affect the tooth longevity, because you're removing some of the stuff. And the replacements do not perform better than any of the other treatment approach. So if you just repair it versus replace it, it's no difference in terms of the repair. In our study showed that the higher survival estimate, even in comparison with restoration that were replaced. So there's evidence that just repairing work as well as replacing the whole entire. Probably it's a lot more conservative, less expensive, and lasts as long or maybe longer.
What kind of studies were those? Were those retrospective studies? Were those
I have
studies?
no idea.
Is that a single study?
I have no idea.
Those two, that was a single study.
Yeah.
Our study.
That's, yeah.
Just some evidence. It doesn't mean that
You'll,
it's still all a matter of judgment.
Right.
Yeah,
Just
what
as you say.
constitutes a repair? What constitutes longevity?
yeah. Oops.
Bet John's not here.
When to restore pits and fissures. So this is about 5-6 scenarios under the same thing. So scenario 6A, patient 30-year-old female. She is in today for routine visit. Has been seeing you regularly for the last 6 years. How would you treat this tooth? No treatment, just follow up, non-invasive, fluoride amide paste, you seal over it, you do PRR, traditional composite or traditional amalgam on this one. We're gonna go back to it. Second scenario, the same tooth, right now we have a little bit of issues going on here. The same patient, the same everything, you've been seeing her, no other problem. How would you approach with this one here? 6C, if the patient come in with more of this, the same patient, the same scenario, would that change any of your options here? 6D, you can see definitely something going on. And then the last one is this tooth here. I'm not gonna comment on that. So, this patient, so at what point, the question was, at what point, I mean, here, 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 4 or 5, so that's progression. At what point would you place traditional composite amalgam? Do you place it at that scenario here? Do you place it at that scenario here, 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 and here? Who would replace traditional on 1? Okay.
It would appear that that's a partial sealant loss on that.
Yeah, you can
area
see.
was to be sealed, and I would certainly just consider some resealing of that.
Okay. Who would, at this point here, would go open it up and you place traditional composite or amalgam?
I would place probably a composite there, only if you are using proper instrumentation, which students basically don't have. It's available in the clinic. Mary Bush provided some of these very small diamonds. They're about the size of an Explorer tip.
Are those the mosquitoes one?
Yeah.
Yeah.
And you can use that to very conservatively
Open it.
see where the stain goes, and I would expect that that one would open up into something more than just a little stain on the surface.
3, anybody would open that right away.
Or I would do the same thing.
Obviously,
Same thing.
Same approach.
Yes.
yeah. 4 and 5, definitely, we're not gonna talk about that. So now, so that's the first scenario. Now, this patient now is different patient. This patient has 12 restoration, existing restoration, has a heavy plaque, and multiple class 5 white spot lesion, okay? How would you treat that tooth?
High-risk patient.
Well, okay. The second one is the same scenario. The only difference is this patient has 12 restoration, has heavy plaque, and multiple white lesions, class 5, that the previous one did not have. So those are the same thing, the same options, the same everything. Would that be any difference in your approach, knowing the 12 restoration, heavy plaque, and the white lesion? Would you approach at least 1 and 2?
See, for the first scenario you gave, I'm not sure I would do anything, all right? No caries, no anything going on.
Right.
Yeah, they've lost part of a sealant, but, you know, what has happened when you've been seeing in the last 6 years? I mean, you could put a sealant, but I think to me, that is a little bit, personal choice. It's equivocal. But when you throw in the next scenario,
This one.
the high risk, then I think you, at a minimum, you go in and you do a sealant. I
Okay,
think you just move it
a little bit, yeah,
one standard deviation to the left or whatever.
right. Now, would that change? How would you do the second one here from the first time, from the first scenario? Would you open that completely as a traditional, or try to open it again very gently to see what's going on?
Well, at minimum, I mean, anytime you approach something like this, I think it should be initially opened minimally and see where you go.
Okay.
And sometimes that may go away before you get to done.
Right.
And just on that subject, this item number 4, preventive restoration, I think is a question in terms of definition. What it is, there shouldn't be any question anymore, since the ADA defines it as preparation that doesn't coincide.
Right, yeah.
But curiously, we charge more for that than we do for it.
For the regular one, I know.
We changed.
No, they refuse to change it.
They refuse to change it.
Joker refused to change it. We talked to him, we sent things, yeah. Okay, so,
How much is the difference is there?
oh,
How much of a difference is there?
it's like $11 maybe?
$11 more or something?
Serious?
163, 150 something.
It should be between the
That
ceilings.
can't, are you sure, our most recent review?
When
We just
was
did
that?
2 weeks ago?
We don't know about 2 weeks ago.
Okay, everything's been, fee revisions are going on right
Okay.
now, so
It'd be good
I'll
to
check.
look at that,
Yeah,
yeah.
I'll check with him.
So with this one here, the 12 restoration heavy plaque, at what, so we discuss it, the question is at what point you go in there. It seems that there is a little bit, maybe shift a little bit here. You may seal it versus not sealing it first time. So for the first scenario, scenario 6, so the 30 years old coming, has no cavities, no nothing. You've seen her for 6 years. Most people they go right away here, 48%. At this point, would they go and they put traditional composite versus the second scenario, the 12 is 33. So there's a little bit shift, okay? So that's where I mean, not much of a difference really, except if take a look.
Dr. Ayub?
Yeah.
Now here we're not considering radiographic findings as well, but wouldn't that be a contributor to our initiation treatment as well? Like we would have blood wings, and at certain points, I mean, perhaps in the third level there you would see DEJ enrollment. So, I mean, that will come into play, right? Do you expect any of the first two not to show radiographs?
I don't assume anything. That's what they show. That's what you think. That's what you see. Let's say if you don't have any X-rays, how would you approach that?
When you're in heaven, you don't need X-rays.
Yeah. The conclusion is sealant placed over non-cavitated lesions significantly reduce progression of the lesion. So basically, if we go back, the recommendation that they were talking about is number 1 and number 2. Most likely, you could use sealant on it, and even if there's nothing in progression, in the future, that will lessen the progression of the lesion. So you are ahead of that. So sealants placed over non-cavitated lesions significantly reduce the progression of the lesion, and then when lesions are sealed, bacterial number decreased by as much as 100-fold. Now, what does it mean clinically? I have no idea. What that 100-fold means, how significant is clinically in terms of the bacteria, I really don't know. It was not really clear in that one here.
You have those articles in the folder.
Yeah, we're gonna give you guys the articles and stuff like that. So for patients of all ages, Pitt and Fisher sealants should be placed on early non-cavitated carious lesions to prevent progression of the lesion. That's basically the recommendation on that one. Now this is a reality check that's about the Explorer, okay? So I'm only the messenger, don't kill me, okay? Okay, all right. So basically there is a theory saying that if you go ahead and vigorously use the explorer, when you explore any white lesion or possible, you think aneurysmal, you think it is cavitated or non-cavitated, you may cause cavity. Now, it doesn't mean that you cause caries. It means just ditching, and you create a place where the food can go in there and then develop into maybe lesion later on. Detection of Fisher caries lesion should rely on sharp eyes and not sharp explorers.
What if you don't have sharp eyes?
Well, use your loops.
Yeah. So that's basically what they're showing. Okay, so, you know, this is the white lesion. They're going with the explorer. To me, it looks like it's chisel. It's not an explorer. I mean, what's vigorously mean? I mean, it's way too much. The explorer tip can easily damage the white spot. Detection of Fisher caries lesion should rely on sharp eyes, whatever. So,
You know, I've got to ask, you know, the attrition of mastication is not going to do the same thing as a sharp explorer on the occlusal surface? I mean, you know, if you're that concerned about that,
Well, I think that, I think the point of the diagnostic criteria being visual, I think, is significant in that you don't, if you are looking at a clean surface, I mean, I would use an explorer to maybe clean debris from the surface so you can see it. But anything that would be carious would have visual cues, visual clues that you could
Right.
see. And what information you can gain from a sharp explorer is pretty much irrelevant, I think. If there's a hole there, you can see the hole.
right.
Sticking an explorer in it doesn't increase your level, I mean, of certainty that there is a hole. If there is no hole, you're going to look at the color around the groove, the relative or the apparent depth of penetration of the discoloration, any shadowing around it, and those things, I think, are what you should base your diagnosis or your decision to proceed with anything on.
are we talking about occlusal surfaces?
Occlusal surfaces. Occlusal surfaces.
Not smooth surfaces?
Not smooth surfaces.
Not smooth
We're not talking about smooth surface, but looking at occlusal surfaces.
Yeah, it says
If
here.
going back to your sharp explorer, you can get a false positive with a nice sharp explorer and steeply inclined grooves and say, oh, I've got a catch. But there's no visual clue to anything. And so you would have to discount that as being inappropriate in terms of a diagnostic procedure.
Yeah, but do you think using it, I mean, I don't know what vigorously they meant by it.
Well, the point is you don't have, I mean, there's no point in using it.
Right.
You've got no need to use an explorer, so it's irrelevant, I think, whether it causes damage or not. The information gleaned from the use of the explorer doesn't do anything to change what should be your diagnosis based on your visual examination of the pit and fissure lesion.
Okay. So are we agree with that? I mean, because a lot of people, they think that having the explorer is very important because they can clean all the cruds and stuff sometimes, and they do stuff, debris and stuff, right. Right.
And if there's something that you can scrape out, but you're not trying to stick it in for diagnostic purposes, you're using. My thought of the use of an explorer is to clean the area so you can see.
Right.
But that's the only.
That's it.
I'm using it as a cleaning tool, not a diagnostic tool.
Okay.
I've been trying to make that point for about 20 years or more.
Okay.
I like to make it for myself sometimes. I explore this. Finds its way in.
Haven't patients always accused us of causing gift?
Well, some have, yes.
Yeah. Gonna talk about interproximal lesions. Okay, so scenario 8. This patient, a 30-year-old female, she's in today for routine visit. She has been seeing you regularly for the last 6 years. At what point would you open the tooth? Is it point 1, 2, 3, 4, 5? The same scenario, the patient now has 12 restorations, heavy plaque, and multiple class 5 wide spot lesions. At what point would you open 1, 2, 3, 4, 5? All right. So this patient is okay, no problem, no caries, you see him regularly. Would you open number 1 into proximally?
One of the things that you're not bringing into play here, and you have been seeing this patient regularly for 6 years, so this is not your only image. You have a history, and possibly a history from where the patient had been before. So I think this is a very important aspect of determining what you're going to do, when you're going to do it, is your radiographic history on this.
Right. But here, I mean, she's coming in today, you've seen her routinely for 6 years. So you know the history of her.
Right.
Okay, yeah. So would anybody go, knowing all the history, knowing all the previous x-rays, would you, whatever you see right now, would you go in there and open number 1?
No.
What about number 2?
Well, it depends on what the radiographic history shows.
So if, let's say, if you started like that and that like this, you would open it.
Right, give it some thought, because that is at least 90% penetration of enamel radiographically.
Right.
There. Clinically, it should be indented.
Mm-hmm.
So I guess the question is, do you subscribe to newer techniques of breaking out the old Farrier separator and prying these teeth apart and placing a sealant in between the teeth?
Yeah.
Huh? Well, there is
I know,
something.
I know, we were talking about that.
Okay.
It's kind
Yeah.
Well,
of- It's a student being able to do that.
yeah, I would start giving this some thought.
Thoughts, okay.
If I'm seeing
Progression. Right.
Progression.
Okay. Obviously, number 3, it's indented, 4 and 5. So now if we go to the second scenario with 12 existing restoration, heavy plaque, multiple class 5 white spot lesion. What would you, I mean, number 1, most people won't do it.
still not.
Yeah. Number 2,
Probably.
probably. Okay.
Again, looking at history.
Right. So the answer were 47% of surveyed, believe it or not, surveyed dentists, they said they will go 1 and 2.
They would?
They would. 47%. They said they will go 1 and 2.
Doesn't it say they would not?
No.
It's real confusing.
It's confusing.
He
John's.
went over it with
John.
This is John's lecture that he gives, and
Now, the 12 restoration guy in the heavy plaque and everything, now it went up to 78%. They will do 1 and 2. They're saying that 78% mostly was for number 2, that they will go in there. Number 1, out of the 78%, they said they will consider other things, progression and the whole thing. The same,
There's one other factor
yeah.
that I would bring into play on this, assuming I had it to go by. If I had another tooth, same mouth, that, let's say, seemed to appear a little bit more of a problem, but not quite to what you have in 3.
Yeah.
And I decided to go ahead and do that one, I would then
Make a decision on,
based on what I found there,
right,
to either do or not do number 2.
okay,
So in the given patient, the radiographic presentation is a certain thing, and if I find that, if I go in there and I find that it was only an enamel, I'm sure as hell not going to do the other one. But if I find that it is grossly different in its extent than what I expected, I would then go after the other one as well.
Then we're going to get a new x-ray machine.
Well,
Yeah,
Can you back up to scenario number 8?
yes.
With that scenario, if the situation is number 1, or maybe even number 2, how often are you going to take bite-wing x-rays?
if I've seen progression, let's say I'm on a 2-year or so interval, and I see that I've got number 1 in my first series, and then in my next, 2 years later, I've got this one, I might consider looking again in 6 months.
So you're going to take x-rays every 2 years?
Generally, I look for about 2 years, sometimes 3.
Right.
Yeah.
I mean, I think there's confusion in our clinics in terms of that as well.
Other issue, Hadi, I don't know if we are going to talk about that later. Right now, we are talking about the treatment. How
Sure.
about prevention? How about prescribing fluoride for the
Oh.
patient? Is this-
Well,
That's, it's coming at the end, yeah.
There's coffee in the back, just in case.
Okay, there's a lot of changes in terms of the wording, the word watch. Basically, if you see an early lesion, white spot, maybe this one here, or maybe even this one here, people say, okay, we're gonna watch it. I guess this is now is an obsolete term. What they want us to use right now, basically the term is, is to monitor. Monitor means, basically the way they define monitor is you're not just watching and not doing anything. Basically using whatever is in your power or under your, in your arsenal to use in terms of fluoride, amide paste, and that the watching over time, they call it monitoring.
Okay.
It's more active,
We need to use that term then, when
monitoring.
we're charting, deciding.
Basically watching, you're standing in there, that's how they're looking at it. They're standing in there, you're not doing anything, you're just watching it getting bigger or grow bigger.
Is there a line item in our treatment plans for that?
No. Versus monitoring,
The problem list, you can put that.
Right.
yeah,
I'm just
so
wondering how we should
basically.
universally.
What I would do on the treatment plan is, what I do with many items, is we write up the treatment plan, and then
In the notes
usually in the
down?
blank space,
Yeah,
write in to reassess proximal lesion number 3 at next
Recall.
recall,
right,
At the base of the,
or something.
yeah,
okay.
okay. I mean, that's a diagram of, basically this is always should be treated operatively when you can see it is all the way in. D1, which is, it's penetrated in the dentin, may or may not be cavitated, could be about 50% they're saying. The cavitation is more likely in high-risk patients. The cavitation is more likely when the gingival papilla is inflamed. If you see the gingival here, that means probably there's accumulation of food because it's cavitated. That's it for now. Okay, do you guys, you want to have 5 minutes break, get some coffee, then, because we have another, or you're okay, keep going. Keep going?
Yeah, just go take your break when you need it.
Yeah, okay.
Second.
Root caries lesion. Scenario number 10. What would, I mean, you can see it obviously. You can see it also here. The question is, what lesion, what kind of restoration material here, restorative material use, and why? What is the most proper for this one here?
Yes.
GIC. Okay, let's see. Okay, so it's a glass ionomer. The material of choice.
Patty, I'm sorry, nobody mentioned that there are donuts and yogurt also.
Oh, there is?
That was a treat for the dean's office, I think.
Really? Okay, yeah, there is yogurt and the thing. So if you look here, it says the material of choice, most root caries lesion is a glass ionomer. Okay? Now, according to the evidence, glass ionomer restorative material actually does bond well to root surface, reduce the chance of recurrent caries, can help remineralize demineralized tissues or tissue, inhibit demineralization of adjacent tooth because of that proximity. Recharged, this is, I'm not really sure, recharge when exposed to fluoride are the best material for patient with xerostomia. I'm not really sure about recharge when exposed to
I
fluoride.
think when you use topical fluoride or any kind of fluoride in a toothpaste or whatever, then the glass ionomer supposedly.
I mean, is there really evidence that it's,
They measured that in vitro, that it does recharge with fluoride.
in vitro?
Yeah, in vivo, I've never seen it, but, in vitro, they've shown that.
Okay. All right.
So what
Composite, obviously,
Very temporal effect.
right.
composite resin is not the best material for treatment of root lesions. Often not possible to isolate well, does not release significant fluoride, and more marginal leakage than a glass ionomer. Here we have Fuji 9, we have the triage, and then we have the Fuji 2, which is resin modified glass ionomer. Advantage of the resin modified glass ionomer on root surface is significantly better cervical margin adaptation than resin composite, reduced post-operative sensitivity when it's used, reduced demineralization of adjacent to the gingival margins.
Roddy, can you talk about the prep a little bit?
It's coming.
Can I just ask a question?
Yes, sir.
Is it just me, or in general, do people find the handling of like Fuji 2 to be more difficult than Fuji 9 in terms of placement?
Exactly opposite.
Oh, I agree with you 100%.
Yeah.
But the Fuji 2 is more difficult than Fuji 9.
Yeah.
Yes.
I have.
And I would exactly say the opposite from my experience.
I
In
mean-
a private practice.
Fuji 2 is a LC, right? It's like.
Right.
Yeah,
Yeah.
I don't like it. I'd
Well,
much
the
rather
biggest
use
problem-
a 9.
The biggest, I really like using the Fuji 2 LC, and the biggest problem is the apertory light. If you, I was having all kinds of trouble with it when I started
Sets up
using
so
it.
fast.
But if you turn your apertory light away, and if you have one of those little yellow shield lights, you can use that. But if you turn the apertory light away from it, it changes things significantly. You still have to be able to see what you're doing. Sometimes I'll just, if I really need it, I'll just move it a little to the edge of the field, but usually I'll just flip the light away and use the material, and it works very well.
Now, my problem is with the finish, with the Fuji 9, I can remove excess so easily, and I cannot with the.
To me, the consistency, when it starts out, it's too runny,
It is a little runny at first,
I'm talking about the LC.
LC, yeah, yeah.
And then, I never know when to start manipulating it, and if I do it too soon.
You pull out of it.
Contoured, if I
Yeah.
do it too late, then I don't get it contoured. I mean, I don't have that problem with the Fuji 9, I guess, for whatever reason. I mean, the
Yeah.
consistency stays pretty much the same from the time you inject it to the time it gets polymerized or hardened, or whatever it does.
But it's not an LC, and I'd say.
No, I know it's not, but on a posterior tooth, I mean, just because of my, I guess I may be
Now,
inept.
can you add to the 9? I don't think, can you add 9 to 9? I was under the understanding that was not
No,
addable. You can't add to it if you have a deficiency. You can't get another comparable and add to it. But, and then so, certainly in the student setting, you're going to have to do multiple additions. Now, what I found works really well is injecting the material and then just taking a Loma Linda instrument and just kind of swiping it. I know it's very fluid, but just kind of swiping a fair amount of the excess off to either side, and then curing it, and then I use a sharp Hollenbeck to scrape away excess.
Pat, do you use, what do you use a bonding agent on an unfilled resin on your instrument when you do that?
No.
No.
See, he always lifts if I don't do that. Always lifts right out.
I generally wipe it with alcohol.
Oh, that's
No, I
not
just-
good for the surface.
I just use a clean instrument, a clean Lomolin instrument, and just, as soon as I place it, apply it, and just smooth, or just kind of swipe excess. Try to just swipe the excess in two directions so that it doesn't all go one way.
I tried to do that.
And then I have to make sure that I don't try to play with it too much. You know, just kind of get it done and say, okay, don't touch it anymore, cure it, and then I just I sharpen the edges with my Hollenbecks and I just scrape them off.
I think I need to see a demo.
Yes, we need a demo of that. And then, what do you finish it with? Do you seal it?
Seal it.
You seal it.
Fuji coat or G-coat or?
Any of that sealing.
Yeah. Okay, so I'm sorry, go ahead.
Contour street, the minor street.
Miles? No.
Contour street.
No.
No. No,
Or the
just,
press line.
yeah.
Yeah,
Yeah,
just direct hand out.
Just direct place and swipe off the excess and cure it and finish.
Because you can always add to it, the LC.
Yeah. Okay, so, but also sometimes amalgam could be the only material to use because probably we cannot, either because of access or lack of isolation for moisture. So amalgam is still in play on root surface. So you can see it here. You can see it under here.
I think most of those situations would still be amenable to the glass
A
animal.
glass, I agree, yeah.
Just have to get access and isolate.
Okay. Oops, sorry.
And more conservative than placing an amalgam.
Let me see.
Placing an amalgam, you got to prep.
But the biggest disadvantage I find to placing amalgam in many of those situations is the access that you need for condensation.
Yeah.
Because you have to be able to orient your instruments properly, and sometimes you just don't have room to do that. And I find that GIC works really well in many of those situations. And also in conjunction with using some certain matrixing techniques, you can use that to enhance your isolation and also get it to places where you'd never be able to place any other material.
Okay, so regarding that, technique is coming. We got your technique here today. Scenario 11. This cavitated root lesion, tooth number 1, can be detected from the lingual near the gingiva. How would you approach and treat this lesion? It's all the way down here by the gingiva. You go amalgam, you go resin, you go from MO or ML resin or ML glass ionomer. What do you guys?
I would probably, if that is root lesion, somewhat accessible from the lingual, I would use the GIC, but I would make sure that in that situation, I could do rubber dam isolation and isolate that, expose that.
Appropriate, yeah.
Quite well.
Okay. Yeah, it's the mesolingual glass ionomer. Let's see how this tooth was treated here. Look at that.
Ooh, boy.
Yeah. So also we have, that's the same one. Should be access. You go from the lingual, open it, and they're showing you here the technique of the matrix, but I'm going to show you the one, okay, so this is better. So we have this root caries lesion, is trapping plaque, okay? Access is difficult, because of mesoconcavity and the contour also is important. So you go ahead and you start to clean it. You put calcium hydroxide liner in the deepest part. And then the matrixing, this is a Dr. Hart technique, okay? That is a band and retainer are placed You can see that. Then you use a Hollenbeck carver or any instrument you like can use to verify the gingival adaptation. Okay, make sure it's adapted well. And then you get the ball burnisher and you go over it to locate the preparation because it's going to sink in. You can see that's the preparation underneath it. Then you make a hole with a round burr and a high-speed handpiece right in the middle of the preparation under the, so you can see it. See that? Now the question is going to be for Pat later on is it size 4 you used or 6?
Hole,
Yeah,
just big enough for the tip of the instrument.
to go in. Okay.
So it's probably more like 2.
Okay. This hole allows visualization and preparation, confirmation that the band is properly adapted to the preparation, so you can see everything. Then you get, you mix the glass ionomer, whatever it is, and then you go inside with the tip, and then you fill it all over, and as you pull out, you keep on filling as you're pulling out. The tip is removed while continuing to express the material. And you start removing, you remove all the excessive material, make sure it's a flush with the band. Now the material could be light to cured if it's Fuji 2, or it could be self-cured if it's Fuji 9, you just leave it. Then you want to remove it. The best thing is try to cut it and you remove it, or you can loosen the band and you try to remove it that way. It says if the material is light cured, light can be used again. After you remove it, you cure one more time, make sure that the restoration absolutely cured properly and adequately. Now with number 12 scalpel, you go in there and you start removing all excessive material, and you flush it really nicely with the tooth, and you put after that the resin sealer over it, and here you go. You can see.
Buddy, no dam?
I guess here maybe was hard to put the dam on. I don't know. This is not my case, so I don't know
I
really.
know, I just want, what's our,
If at all possible, I think you should use the dam. And I think that case probably could have been done with proper clamps, extra clamps and such. Probably would have given isolation. But if it's felt that you can't really get down there and there aren't too many, I've only had a few that I can't isolate. And if you can, sometimes you don't even need that dam. I mean, it depends how available it is, and how you have it to work with. Here, I think we're probably trying to use the band to, in part, to seal to isolate it.
isolated?
Can I just,
No, go
can I
ahead.
just ask that? In regard to the question earlier that Dr. Kim had asked, why would you not use that same technique, right, on a class 5 that wrapped around to the proximal?
Usually because the class 5 going around goes too deep cervically relative to the proximals, and it's hard to get a good adaptation to the facial surface. And if it's out there in the open, I find it easier just to place it.
But I mean, to me, you can festoon a band so that the
Certainly,
what goes
yeah.
across the
Yeah,
facial
you could certainly do
is
that.
deeper than what's going proximal, and
Sure.
and it limits what goes into that proximal, sort of saves the problem of having excess you got to get off.
Sure.
Going into the
Yeah, if you can
proximal.
reasonably adapt something, fine. I don't have any problem with that.
I mean, it just seems like, maybe it's just my difficulty in handling the Fuji 2, I guess. I mean, that seems that would solve my problem.
Well, I did one, actually, a couple weeks ago where I did use the band.
Yeah,
And,
that's the question to him.
to limit it, but I didn't do it with the whole technique because of the way I got the band on. It actually came away from the buccal surface a little bit. And so I had my gingival and around the line angle all isolated with the band, and then I just injected into the part that was open, got a little excess out there, and cured through tooth structure, took it off, and had mainly just the occlusal margin to finish.
Pat,
So,
question, I'm sorry. Always you prefer to make the hole when the band on a tooth, or can you kind of estimate ahead of time and you started at least?
I'll usually put the hole in before I put it on.
Oh, you do that, okay.
Yeah, I don't do the ball burnisher thing.
Oh, okay.
Yeah, I make the hole where I think the lesion's
Gonna go,
tie it on.
right.
Look at it. And that way, I'm not going kind of blind as far as, you know, like, okay, this is probably where it is. And not knowing exactly what I'm going to punch through. And I can also clean up the hole.
Right.
If there's
From the-
some burrs around it that
Yeah.
might lock in or disrupt the restoration. So.
Especially for students.
So, Dr. Hart, the technique you just described, I mean, anytime you put a matrix to a class 5, you would expect it to, you know, move further from the tooth coronally where you can actually inject the material. Did you find the cleanup to be very tricky? Did the excess extend interproximally, or was it
Not
more
particularly. It was
controlled?
mostly occlusal, and in there I used because of the amount that was open there, and that I didn't want to either instrument or compress it against the tooth. I just used a diamond to take away the gross ball.
Because I mean, that's nice because you can verify adaptation visually and establish isolation at the same time.
Yeah.
Yeah.
But if excess cleanup is not a natural thing.
No, it was, in that particular circumstance, it was not. It was just a bulk of material where the band came away from the tooth on the buccal surface and easily accessed and cleaned up.
Yeah, I think if it's one surface, you can do it without a band, but when it wraps around, as it does sometimes, onto the prosthesis.
Yeah, yeah.
Then I think,
Yeah,
using
then
a
a
band
band
might
is
be
probably,
good.
Yeah.
You know, and you can, I mean, you can take it, you can just soak a cotton pledget in some binding agent and put it in there and then cure that just to hold it against the tooth.
Sure.
Okay, the last section is the caries risk assessment. We have a couple of scenarios. Scenario 12, so you are supervising an exam on a new patient to the school. She's 25-year-old. She has 3 occlusal lesions. She has numerous interproximal lesions in the enamel. She has not seen a dentist in 5 years. She has visible plaque on her teeth. She sips cola all day at work. Now, what does it mean by sips? I don't know. Some people could be 2 liters, could be 40, I don't know. But that's the way it is. Right, so the 25 years old, you've seen her first time, no history on her. We see 3 occlusal lesions, numerous incipient lesion, and hasn't been a dentist for 5 years, and visible plaque, and then the cola thing. Now, what is her caries risk, and what fluoride regimen should be prescribed for her? Is she high risk, is she moderate, or is she low? It's high. Okay. The second one, scenario 13. Now you're supervising the exam on a recall patient. He is 50 years old. He has no new lesions, okay? He has many interproximal amalgams, which he says were placed when he was in college, so about maybe 25 years. He has some exposed root surfaces. He admits to eating sugary snacks 4 to 5 times a day, Holy crap. His oral hygiene is good. Okay.
290.
Yeah. So basically, okay, so he's a recall patient. That means we've been seeing this patient. 50 years old, had old amalgam for 25 years, no new lesion, exposed root surfaces, sugary snacks. What do you think, guys, the caries risk here?
There's two risk factors.
Go ahead.
Moderate.
Moderate? Okay. What do you guys think? You think it's moderate? Okay.
I would say college causes decay.
That's true. So it is high risk, the first girl, the 25 years old, because she hasn't seen in 5 years, visible plaque, sips cola all day, and in our CRA sheet, you can see the visible, like, cavities or lesion, yes. Radiographic proximal lesion, yes. And then a plaque, yes. I mean, she has almost the factors that categorize her as high risk. For scenario 13, you guys, you're right also, it's a moderate risk. I mean, if you look at the exposed root surface, sugary snacks, but no new lesions. So the exposed root is a little bit of risk. The snack, more than 3 times a day. So the fluoride protocol for age 6 and up, or that we adopt here in the school, is for the high-risk patient, we would like to see the fluoride varnish every 3 months, and prescription toothpaste used twice a day, including before going to bed. For moderate risk, fluoride varnish every 6 months, over-the-counter toothpaste, fluoridated, and maybe OTS rinse 1 to 2 times a day, and low risk, just toothpaste twice a day. Now the question here, if a lot of our patients are high risk, how are we going to manage this? That's where the problem is.
If a patient is undergoing protracted treatment, you have the opportunity to see them in 3 months anyway, so you can easily do a varnish. It's not particularly time consuming to do it.
The cost.
Well,
What is the cost of fluoride varnish?
it's in the teens, isn't it?
Yes, like 16
14, 16?
Per arch?
No,
Per tooth?
no.
per application.
Per application.
Per tooth? How much you charging, doctor?
You're going to do the whole mouth, right?
I don't know what the,
Yeah, it's about $16 per application.
Yes.
From a conversation with John a few weeks ago, we noticed that the students sometimes did not receive immediate instructions on how to apply fluoride varnish. And we were thinking on how this can be incorporated. Now, we had a discussion about possibly introducing it in 822, where Dr. Brown's class, where they can apply to each other. Is it possible to introduce like a small varnish applying clinic into that course where second-year students can be instructed and maybe apply it to our high caries risk patients? Just a varnish clinic where they can just see patients, apply varnish, and then get more confident in
I don't know. I mean, you have to talk to.
Technically, it will not be easy because you will have to bring the patient.
Right.
an exam, right? They need an exam and a prophy every 3 months.
Well, they need a varnish. They need an
Yeah.
exam and a
They need an
varnish.
exam,
Yeah, just
prophy.
polishing and,
It's a procedure. You can brush their teeth and floss and get the floss.
And that brings
You don't
me
have-
to the
you don't have
other
to polish
issue.
them.
I don't know if, again, I have completely different observation to Dr. Gallup here. It must be me. I don't know if those are only my students, but they have that misconception that we prescribe fluoride and do the fluoride varnish on a recall visits only. Let's say I have a brand new patient, I do the treatment planning, especially now in the end of the semester. The patient will not receive the prophylaxis till August. I insist on prescribing a fluoride, and the student's telling me, oh, I'll do it in August when I do the prophy. I'm not sure if John shows them those scenarios when the recall patient comes and that it comes from, but it wasn't one student, there were two of them. And I don't know where they did get that idea from, that we do it on a recall.
Okay.
There's one other little thing about fluoride varnish and how we do it in the clinic, which I thought was very interesting last week. And a student wanted me to sign for fluoride varnish, and I said, okay, well, when are you going to apply this fluoride varnish, since it was sort of the end of the session? And, well, no, we've been told that if we don't have time, we can send it home with the patient.
I heard that too. You're absolutely right.
But we know
Yeah.
that they were not told that. So,
Well, somebody's telling them that.
No, somebody, yeah, that's true though.
okay.
Yeah.
I don't know who, but
Okay, so this is not take home. All right.
Well, it has been suggested by manufacturer, well, actually, that was on my page too.
Yeah.
My page.
One more question, Fanny,
Yeah.
because we are talking about the cost-effective treatment. As we know, majority of our patients are not very wealthy people.
Right.
Even if they buy the Prevident from us, it's $8.
Right.
It is relatively expensive.
Mm-hmm.
And the students are insisting to use it twice a day. I kind of frankly would go even further if they use over-the-counter in the morning toothpaste.
And before they go to sleep.
You know, they use the prescription line. At least there is a compromise, but in my humble opinion, it's a reasonable compromise. Did we introduce any idea?
Sure. Sure.
And having all the smart people also in the room, I have one last question. I just found out from the patient who was told in the pharmacy that the Prevident rinse is discontinued. Is that correct information?
Continue? Discontinue?
Discontinued. I have a patient with a very poor dexterity, so that's why I wanted to go with the rinse, not with the paste or toothpaste.
I don't know.
And the patient was trying to fill out the prescription, and the pharmacist said it's impossible.
It's another
I
thing.
didn't have a chance to investigate that
Yeah, yeah.
last Friday, so I just thought to with all this
That's the rinse.
website,
I
somebody
mean, it's a website.
I went to the website and it's available, or if nothing was, you know, that is this.
They're talking about, yeah.
So.
I mean, we'll figure this out. We can, it's not a big deal.
back on the fluoride varnish in the clinic to show, I think that's a good idea because it's not real easy to put on.
No, it's not. I know that.
What, varnish?
Yeah.
And it does take some time. It's certainly far more time consuming than doing the traditional tray fluorides.
They apply it on their own, especially in the perio clinic and the prophy clinic. They're on their own. The perio is not going to supervise them applying it.
See, that's the problem.
Nor are they going to come and have one of the restorative faculty come and supervise the application. So basically, they have no guidance. And that's the discussion that was between me and John. He said he was concerned because a student called him, can you please show me how to do it? And then we started thinking about possibly showing them at an earlier level, and maybe 822 is a great opportunity. If the cost isn't a problem, we can contact manufacturers, get samples, and have the students apply on each other. At least, but if we need to be applying them for the patients, so maybe it's something that.
Well, the good thing, I mean, I had the same,
I think it's a great idea. They like those experiences.
Yeah.
Possible.
I mean, I had this conversation with John. I suggested so we can have better compliance also in terms of doing this in the clinic. That let's say when we get a new patient, the question you asked about the new patient, Benita said that nobody wants to do it. They think they're going to do it on the recall. Let's say the operative or the restorative dentist will be supervising the first application in there, okay? But then on the recall, should be the perio faculty supervise that. So that would take the burden also from us, because to go leave 6 students doing irreversible things, to sit in there, watch the varnish, and I mean, it's not gonna work for us. So I think that's one thing, if we can split the duties with perio, I think that would be a good thing.
Or provide them with a video along with introducing them in the second year, they practice on each other.
Yeah,
I think
yeah.
that's a good
They're
start.
doing it on each
Did
other
they learn it
is
in
great.
perio? Did they learn it in their
I do
initial
not know, but to
perio?
my knowledge, the student approached him and said, we had no instructions on how to do this. Can you please watch me do it or talk to me?
Okay, so they
And
haven't
that's
had
the
it.
concern.
They haven't had it, yeah.
They have not, no.
One of the great things about doing it on each other is that they get to feel what it's like.
Yeah. And then if the cost is a problem, we'll get free samples from
I think we should be able to do that.
You just have to be sure there's no concern with human subjects in terms of compliance.
Oh, good point.
Well, no, but it's no difference between when they give injection to each other.
Yeah, without
I would just clear it before you start the thing. I mean,
Because you don't have a diagnosed high-risk situation and you're using a medicament of some sort, so.
Then also at the same token, why are you giving an injection, a block, to a student who doesn't need
Yeah,
treatment?
because presumably that particular thing has been cleared.
It just makes sense just to,
Oh, sure, yeah.
You know, it may not be an issue,
Right.
but the question would be good to ask.
Good to ask, okay. All right, so the poll was, they were asking the dentists with Norton here, the research said, do you assess caries risk for individual patients in any way? 85% of dentists responded yes. So the paper is saying that probably could establish that dentist or dental school is practicing below the standard of care if patient's disease is not being managed. So, I mean, 85, I'm not sure if that high or low. Cannot be 100%, I don't know, but that's basically their finding was that we may be practicing below the standard of care. Last slide. A recent small chart audit showed only about 50% of our faculty complies with CRA form and a fluoride protocol. So basically, we really need your help, and the student need consistent teaching on caries management. So 50% is really low, very, very low for our clinic. So the question is it the faculty's issue? Sorry. Is it the faculty issues, or this is the student not doing it, or is it both? I've heard I was there, I have heard a couple of faculty saying, just don't worry about this right now. Let's take a look at the caries. I've seen them, they dismiss the CRA. But also I'm seeing a lot of students, also they don't do it. So whose responsibility is that?
you know, I think, you know, and I guess I've been guilty of this myself. Initially, when, you know, the qualifications for high risk, moderate risk, and everything else, you know, you get a patient comes in and they've got one carious lesion and they're high risk, and I said, well, what are you talking about high risk? You know, and I didn't understand, and maybe I didn't pay attention. I think the reason for having the categories of high risk, moderate risk is what you prescribe and how you go about
Prescribing.
informing the patient. You know, in some respects, it has less to do with the severity of the degree. When you say high risk, you think, oh my God, you know, their mouth is in trouble. But it has more to do with a corollary of what you do when a patient has a carious lesion. Mm-hmm. You know, and I don't know that message has really been made clear, or maybe I'm the only one that didn't understand it.
Well, apparently we didn't make it clear because we've gone over it a number of times, so I will take responsibility with John for that.
No, I mean,
because we had the same conversation last year. And I think it did get better.
It did,
I
yeah.
think it has exactly the same concern. That, you know, okay, there is a form, I'm guilty of that too. High, because
You're
everybody was
supposed to.
high.
We really
But I
stressed the
think-
judgment, though.
Exactly, but I think after the conversation last year, majority of the faculty did improve, hopefully myself included, and we look at that a little bit different. So from that survey, I would be more concerned about that second part, fluoride protocol, because I think it's lower than 50%.
It is lower than that.
It is, because this is very small.
It's a different story.
Yeah.
But the fluoride protocol, I think, is lower than the 50.
The 50%,
There
yeah.
weren't, it was all spread across, tier directors, superhuman faculty, every kind of faculty that, you know, that were represented in that. I mean, so it's across the board, it's not.
Oh, yeah,
maybe I would
it's-
find people I could say, hey, could you just please participate? It's just across the board. And I think it's because we don't know when to do it. It's every patient that's a new patient exam needs to have it. You have to have one done at recall. And if you're high risk, you should be having another one at, you know, whatever you determine to be high risk and treated by a particular protocol, it needs to be at every 3 months. So everyone should be checking that. Perio should be looking at it to make sure one was done. That's all. When's the last time they had a caries risk assessment? And then the students are flipping through, looking through the thing. So that's, you not only do you put it on the chart, you put it in the progress notes, and you just want to ask them, that's all. Just ask the students at those intervals, I think, is what's important.
Davis.
There also was, a fairly exhaustive paper that looked at Caries risk assessment, and how many dentists were doing it in relationship to whether they had a Caries risk assessment protocol in their office, right? This was and there was a direct corollary between whether you had a risk assessment vehicle that you used and whether you did Caries risk assessment or not. If you didn't have a protocol in your office, the amount of Caries risk assessment that was done fell to like 20 or 30%.
So that's the point, trying to get these kids, I think, to accept that there is such a thing, that it's a standard practice, and that they will implement such a protocol for assessment and management in their offices. It may not be the format that we use, which is, this is for kind of a teaching protocol and all that. In your office, I think you can look at the same things.
But Davis is right. We need to explain to the students why we're doing this, and also the same thing for the faculty. So
The students get it.
I know, again, Dr. Maggio reiterates that always with
Over
the
and
students.
over.
So always, in his midterm, in his quizzes, in his final exam, he's always on it. The students will forget. So I find myself, when the student comes in with a new patient, I completed my problem list, my examination, my charting, and I look at them, Caries risk, and they go, oh, okay. And that's how I get rid of them. Okay,
Right.
But in general, they're not that bad. I noticed this year they are much better in that
They're better. It's getting better. We want to remind them. We just have to remind them initially until they get sick.
When I did, we just finished now the orientation for the juniors. I divided into 5 groups for the juniors, and part of the orientation was the Caries risk assessment. We talked about it, we emphasized it, and we almost nailed it in their foreheads. Now, is that going to translate sometime later into an action? I don't know, but at least they've been informed in many different ways by many different people that they need to be done.
I think our biggest problem is with new patients. They're buried with all the paperwork, in terms of, going through and, recording everything, coming up with a problem list, developing a treatment plan. It almost is mind-boggling to me, having been a part of it all these years.
It's exhaustive.
That doesn't mean we shouldn't do it, but
Right.
It's a lot to try and comprehend.
To handle, yeah. All right. So thank you so much. I'm going to end right now.